Okay, so this is the last lecture of this series, also because they want me back at work on Thursdays from next week. But as you know, we are working with Daria and with Godwin, with other institutions also in Italy to try to connect us as much as possible. So I will keep you in the loop for every other case discussion, webinars, and for our neuroscience meeting at GOSH in general. What we really would like to achieve is networking, which whose goal will be for every one of us to learn more and to know where to seek for help when we have a difficult case. This lecture is about epilepsy, which is one of my field of interest, and is really about how we image a child with seizure and how neuroradiology of epilepsy is different from the other fields of pediatric neuroradiology. So this is the summary, and this is a lecture that I did for our fellow here 2 days ago. So it's quite basic, and I know that for some people, like in Nigeria, some of the technical advanced stuff that we use will be not feasible, but it's just to give you an idea of what we are looking for and what should be our approach as radiologists to a child with seizures. So I will speak about some technical aspect of modern neuron imaging in epilepsy. I will show you how a brain with epilepsy looks like. So I will show you some cases, and I will say something about the role of imaging in preoperative planning. Now, this is a book I like very much. It's The Little Prince, and this is a quote for Little Prince. It's the only with the heart that one can see rightly. What is essential is invisible to the eye, but actually we can change a bit this quote using this and say that it's only with MRI that we can see rightly. So, and what is essential? So what we are looking for, what is the cause for the of the seizure, is no longer invisible. And this is the first really teaching point. You need MRI to approach a child with epilepsy. And what you need to see the invisible. So first of all, what is the invisible? So we are looking for a lot of diseases that can give you seizures, but actually the most challenging and also the most common in children is a class of diseases called focal cortical dysplasias. And in order to pick up this very subtle abnormality, we need power, okay? And power in MR means high field. So if you have 1.5 or 3 Tesla scan, you should use them because this will allow a better signal to noise ratio, especially the 3 Tesla, which is the gold standard in the Western world, and at least. And then but you need to be aware of a lot of pitfalls. So we use 3 Tesla scanner. I know that in Nigeria, you guys have 1.5 Tesla scanner or scanner of 0.3 and so on. This is something that I also would like to present a bit in this talk, that we are collaborating with UCL to try to improve the signal to noise ratio in 0.3 scanner in order to achieve a 1.5 quality. So despite you will need ideally a 3 Tesla, there is a lot of you can do in terms of artificial intelligence and post-processing in order to increase your power even with a low field scan. So these are some papers, and they show basically all of them when they compared the 3 Tesla with the 1.5, that the 3 Tesla is better. It's better for almost everything apart from motion, because the more powerful is the scanner, the more you are you have a problem related to artifact, in particular metal artifact and motion artifact. And there are some of these papers that they said that the radiologist, this is 10 years ago, so now we all accept that the gold standard, if you have it, is a 3 Tesla. But some of these papers, they say, you know, the 1.5 Tesla was better in identifying lesions in the temporal lobes, because the temporal lobes were more prone to flow artifacts and movement artifacts and artifacts from the air of the sphenoid. So the 1.5 in some cases was still better. So this is just to show you that the power is not everything. And this is to show you the differences between the 1.5, this is a coronal T2 sequence. Now, you know, you should be able, even if you are not a neuroradiologist, to recognize all the sequences after all these lectures. And you can see that the signal to noise between the white matter here and the gray matter is very different, and the 3 Tesla is definitely better. However, of course, the 1.5 is more readily available. But another important thing that you should note is that here you can identify this lesion, this focal cortical dysplasia, much better than here, where there is where it is very difficult to identify the lesion. So you have power, you need power, but with power comes great responsibility. That in case of MR is great sensitivity to motion. And this is important because another technical thing that you must be aware of when you scan a child with epilepsy is the use of 3D sequences. So isotropic voxel that you can orientate as you want. You can do multi-parametric reformat. That's very important. However, that's tricky in the moment you have some movement artery. You see these stripes here. This is because the child was moving the head right to left. And the problem is that when you acquire a 3D sequence, then you want to reformat in the other planes. But of course, you will have the artifact in all the planes. And so one sequence will give you 3 sequences when you acquire this in a volumetric fashion. But every problem you develop on the source images, you will have in the other images as well. So 3D acquisition are essential because they give you this multi-parametric ability, but also signal to, spatial resolution, which is very high. But of course, you can have a lot of problems. So you need to reduce the artifact as much as possible in the epilepsy imaging. And this means that, for instance, you need to have a very, very low threshold for scan under general anesthesia or deep sedation in these children, because a scan like that is acceptable if you have tumor, for instance. But for a small, in order to look for a very, very subtle focal cortical dysplasia, this will be not appropriate. We use also alternative methods to increase patients' compliance. This is an inflatable MRI scanner. This is Olivia. She gave us permission to use these images in the GOSH website and in our GOSH internal journal. And this is actually an inflatable MRI that costs, I think, £1,000, something like that, and has the same size of a real MR, and the air pumping into the inflatable scanner will simulate the noise of the MRI scanner. So basically, you will show the child not only how our lying in an MR look like, but also in this case, she will be used to the noise of MR. And like that, we are trying to reduce our sedation rate, trying to train the children in staying very still. But remember, the point is to have a perfect scan because we are looking for very subtle abnormalities. And this is just another example. This is a 1.5 spin echo T1. This is a gradient echo 3 Tesla scanner. If you have a 1.5 Tesla and you do 3D T1, remember that the gradient echo T1 are very, very good for the contrast resolution. So this is very, very useful trick. You don't want to use spin echo in T1 for this kind of scanner. So even if you have a 1.5, don't use the spin echo, use a gradient echo. And you can see here that this is the gray matter here, and there is the white matter in between. And here you have a blurring. So you see that the gray matter fades into the white matter, and this is a very small focal cortical dysplasia. The same ability of the 3 Tesla to have this increased signal to noise ratio, so increased contrast resolution, you can see in the T2 sequences. Although, and this is the lesion, although in T2 sequences, remember the spin echo are still better in terms of contrast resolution. And if you want to do a 3D sequence in T2, you will need to work on your gradient sequences, because the gradient sequences are faster, so you can have a 3D gradient, but you will not have this kind of contrast resolution unless you work a lot to your sequences. So the bottom line of that is really you need to sit with your physicist, you need to try and try again till your sequences, whatever scan you have, works very, very well. Another important thing to have 3D sequences is that actually you can do surface volume rendering. Now, we don't like as radiologists surface volume rendering because we can identify, this is the same scan as before, we can identify the lesion here very well in cross-sectional imaging. However, we identify the lesion not because we want to look very smart, right? We identify the lesion because a neurosurgeon need to go there and cut. But the neurosurgeon will open the skull and his vision will be a 3D surface vision. So it's very helpful to sit with the neurosurgeon, and you can have 3D also on the 1.5 Tesla, you don't need the 3 Tesla. And you say to the surgeon, listen, you need to cut from here to there as far as you feel safe, because the lesion that we see on cross-sectional imaging correspond to this shape. Now, so you use, when you sit with the neurosurgeon, you use the surface anatomy. And it's very important. This is something that our amazing neurosurgeon, Martin Tisdal taught me. And it's very nice to sit with him and learn how really he approached this. So you need the surface anatomy, but also you need a multidisciplinary approach. Now, these are, sorry, I'm doing a lot of because I have a very strong headache this morning. I don't know why. I hope it's not Corona. I don't think so. Anyway, you see that you have here only one of these is the MRI scanner. The rest are functional images or EEG or this MEG that I will tell you about, or nuclear medicine. Because the more information you have from different sides, the more sensitive you will be in picking up the lesion. So you need a multidisciplinary approach, that's very important, and you need an adequate protocol. Now, this is our basic protocol. Our basic protocol is a 3D T1, 3D inversion recovery, and 3D flare. And then, because we are not still able to have a very good 3D T2 in terms of signal to noise ratio, we still use spin echo into plans, because here in here you need just one acquisition, then you do the reformats. And then in this case, because we cannot do reformat, because this is not an isotropic box, we use axial and corona. Some other institution I was trained in Toronto, they like very much proton density, which is not really used in our neuro practice, but it depends on what you like. You need again to have an experience to try different sequences and decide what works better. It's important to consider that apart from this protocol, you can add some sequences, and these sequences are specific. There are susceptibility, diffusion tensor. We do diffusion, of course, in all our scan, perfusion, and contrast. And in these cases, we need to change the sequences depending on the on the clinical indication. And I will show you some example. Okay, first thing first, we are looking for focal cortical dysplasia in most of our cases, and focal cortical dysplasia are type 1, type 2, and type 3 when are associated with other stuff like hippocampal sclerosis, tumor, vascular malformation, and so on. Now, the important thing is that focal cortical dysplasia type 1 usually is not visible on an MRI. We can have some indirect signs like atrophy, hyperplasia, so asymmetry, abnormal sulcation of gyration, but this is very tricky. And it's tricky also for the pathologists. You know that the pathologists, they are thinking to put out this focal cortical dysplasia type 1 from the classification because they are not consistent in diagnosing it. So it's quite tricky for them as well. But the focal cortical dysplasia type 2 is what gives us a lot of satisfaction because it gives you, can show blurring of the gray-white matter junction, as I showed you before, and also hyperintense signal in the subcortical white matter in a specific subtype, which is the type 2B. So you can do almost an histological diagnosis, although not all the type 2B shows this hyperintense signal. Now, a bit of interactivity, you can chat the answer if you want. So, and this is an easy case. So tell me, what do you think is that? What's the what are you seeing in this case, and if you can do a diagnosis? Someone want to chat? No? Okay, so I will describe a bit. Oh wait, I have a chat here. Yes, so they say tuberosclerosis, fine, that's the right diagnosis, but because there are subependymal nodules here, but the most important thing, there are a lot of areas of hyperintensity here in the subcortical white matter. Now, this we call in tuberosclerosis tubers, but can you tell me what are histologically tubers? Well, basically, tubers are focal cortical dysplasia type 2B histologically. So basically, when you see something like that, what you are looking at are a lot of focal cortical dysplasia type 2B. And this is exactly what we see in tuberosclerosis. But because there are a lot, it's quite easy to do this diagnosis. And we have a lot of subependymal nodules. There is something else that we have in the tuberosclerosis, which is a SEGA, so a subependymal giant cell astrocytoma, and this is typically in the foramen of Morrow. Now, we are not 100% sure when something that is a subependymal nodus on the foramen of Morrow becomes a SEGA, but what we are calling a SEGA is something that is growing over time, is more than, and/or is more than 1 centimeter, and especially we become a bit nervous when it has associated hydrocephalus. So this is tuberosclerosis complex, and you have a diagnosis that is a genetic diagnosis, tuberosclerosis complex type 1, sorry, TSC1 and 2 genes. Now, when you have an isolated focal cortical dysplasia type 2B, this is a bit of a problem because basically it's more difficult to pick it up. You don't have a lot of lesion as before. And look at here, this is exactly the same histological entity, but is isolated. So this is a focal cortical dysplasia type 2B. And this hyperintense signal seems to be due to the histological characteristic of this dysplasia that are balloon cells, as you can see here. So that's very, very important to keep in mind. But also sometimes focal cortical dysplasia type 2B do not show this hyperintense signal. But look at the flare and at the T2 for this. Another focal cortical dysplasia type 2. So can you chat, guys, where is the lesion? So this is the right side, this is the left side, this is the frontal lobe. Where is the lesion? Is on the left or on the right? That's very easy. So yes, it's on the right, basically. Now, what's the difference between this lesion and the one I showed you before? There is no hyperintense signal of the subcortical white matter, but because actually there is no myelination. So you remember that I show you the process of myelination on MR, and you see that there is a very, very large areas of gray matter, which is quite blurred, but there is no hyper signal in T2 because the white matter is already bright in T2, dark in T1. This is a neonate. So remember, in an infant, you can have only the gray-white matter blurring, but these are general characteristics of the type 2B, but remember that in the infant, the appearances are different because you don't have myelination. There is another important thing, guys, you need really to keep in mind. Because the myelination start to kick in around 4 months till 2 years, and even longer than 2 years, in both T1 and T2, with the difference that T2 myelination is almost completed at 2 years, while T1 is completed at 1 year. Why this is important? Because in this range, in this between 4 months and 2 years, it's very difficult to image children with epilepsy because the myelination kicking in will create a physiological blurring, okay? So it's very important, if you can clinically, to avoid scanning a child you are looking for a subtle area of abnormality, if it's not a neonate or older than 2 years. Of course, in clinical practice, most of the time, you need to abide, and you have a lot of scans of 6 months, 8 months old children, but remember, this is very, very difficult. Another important thing for focal cortical dysplasia type 2B is the transmantle sign. The transmantle sign is this bundle of gray matter going from the cortex to the ventricle. And this is very helpful because sometimes the blurring you see here can be very, 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 very subtle, but the transmantle sign can be identified, and sometimes it's striking, like in this case. This is from the radiology assistant. There is um, informative paper online. Radiology assistant is a radiology website on epilepsy that we wrote. So have a look if you want something easy to remember the basic concept that I'm telling you in this lecture. This is a bit more difficult. Spend like a few seconds and try to identify the lesion. So this is another focal cortical dysplasia. And the lesion is there. And in this case, you see, I will zoom for you, sharp, this is a 3D flare, sharp margins between the T1, the gray matter and the white matter in flare on the right side, and in T1 as well. But look at the blurring of the abnormal cortex. And this is very, very, very important because this is a focal cortical dysplasia type 2A, but some type 2B can look like that. And remember that you don't have the hyperintense subcortical signal to help you out. This is even more difficult because there is a bit of blurring here. There is a bit of asymmetry. You see here is larger than there, but I have to say that 2 neuroradiologists reported this as normal. And actually, because we were helped then with the EEG and semiology, we decided that this was abnormal. There was a slight asymmetry in the gyration with possible blurring over gray-white matter junction. The interesting thing in this case is that first, you need to analyze these scans knowing where the seizures are coming from. That's very, very important, especially if you don't have a 3 Tesla scanner, because you need to know where to look at. And this case was even more fascinating because it has the child has low-grade glioma, you see post-contrast here, in the cerebellum. So low-grade gliomas and focal cortical dysplasia have been associated with mTOR somatic mutation. So we suspected that this child had an mTOR somatic mutation. Now, other cases, so we'll rapid fire epilepsy cases. This is a typical Meso-temporal sclerosis. You see the hippocampus on coronal is smaller on the left than on the right. And also the normal gyration of the hippocampus here is lost, okay? This is called meso-temporal sclerosis. The important trick to tell to your radiographer is that when you acquire coronal sequences, coronal slice, they need to be inclined along the axis of the hippocampus. Only the coronal, not the axial, okay? This is another case. You see the hippocampus here is brighter and the gyration, which is normal on the right, is lost on the left. These are typical findings of meso-temporal sclerosis and also show you the difference between, I have to say, a terrible 1.5 Tesla. I saw the 1.5 Tesla scanner and also 0.3 in Nigeria. They are very good. But you can see the difference between a 1.5 and a 3 Tesla. Now, let's start with another category. So I told you about the focal cortical dysplasia. Now we'll tell you something about tumors. So there are two main categories of tumors giving you seizures that are in children that are they are called glioneuronal tumor, and they are histologically DNET or ganglioglioma. Typically, the DNET will not have enhancement, although in some book it describes some enhancement. I'm a bit skeptical, but you will have this hyperintense rim of flare signal. Now, this hyperintense rim of flare signal has been described in adults for tumors that are aggressive glioma to distinguish the so-called mismatch T2 flare sign to distinguish IDH mutant from IDH wild type. But in children with seizure, it identifies actually a DNET. So that's very, very important because you can do an histological diagnosis. So hyperintense rim flare, no enhancement. This is this suggests a DNET, while the gangliogliomas will not have this rim signal. And this is a ganglioglioma. Is typically they appear in the meso-temporal lobe and they show this enhancement. Why this is important? Well, two things. You need to change a bit your protocol because you need post-contrast scan, and the ganglioma can be actually quite aggressive sometimes. It's normally a grade 1, but can recur, can become a glioblastoma, so you need to be very, very careful and to do post-contrast every time. Remember, focal cortical dysplasia can be associated with the ganglioglioma, and we call it focal cortical dysplasia type 3B, meaning a focal cortical dysplasia associated with something else. And again, in case of epilepsy associated tumor, please use contrast. Now, this is a CT in a child with sudden onset of seizure. This is a CT without contrast. What you see is basically blood, okay? Now, there is blood, there is a lot of edema, the child has seizure. So we say, okay, this may be a vascular malformation, an aneurysm, but remember that aneurysm and vascular malformation are quite rare, especially the aneurysm in children are very, very rare. So we did an MR and we confirmed that this was an hematoma, but look at here, there is also some sort of hypointense signal in axial T2 and in another area, so in the temporal lobe on the left. Why is that and what we should do? Basically, there are two areas of susceptibility. One is a big hematoma. This is probably a cavernoma. So this should trigger some reasoning, and again, you should change your protocol accordingly. And in this case, you should do a gradient sequence. I show you in the first lecture on development of the brain and MRI to study the brain during development, that the gradient sequences and SWI, so susceptibility weighted sequences, are very sensitive to blood. And in fact, we can pick up a lot of these susceptibility artifacts in the brain. So these are a lot of cavernomas. This one bled before, but actually all these cavernomas here represent again the indication for genetic testing, because we know that we have something called familial cerebral cavernous malformation or cavernomatosis that is being associated with 4 genes. So we know that we need to test this child, and this changed a lot from a management of an isolated blood. Okay, so remember to change a bit your protocol, and in this case to do SWI or gradient T2. Other causes of seizure, well, this is a child with microcephaly, deafness, is quite young, and 4-limb motor disorders. So deafness, microcephaly in a young child, I'm telling you, if you do CT, will be full of calcification with this lumpy, bumpy appearance of the cortex. I show you this case already in the presentation related to the infection. This is polymicrogyria, and polymicrogyria, deafness, and microcephaly are basically related to congenital cytomegalovirus. Why? Because the cytomegalovirus, especially in the second trimester of the pregnancy, can interfere with the normal development of the brain and create this abnormal shape of the cortex. Okay, so it refers to basically an over-migration of the cortex and abnormal organization called polymicrogyria. We can have, however, and this is diffuse polymicrogyria, we can have localized polymicrogyria. Look at this brain and let's zoom it. Look at this area, which is lumpy, bumpy, in comparison to this area, which is quite sharp. Okay? This is a localized area of polymicrogyria. In this case, the child has seizure and hypotonia. And also, you remember in the first lecture, I told you a neonate is normally unmyelinated, the brain, but should have at least the central part of the brain, the posterior limb of the internal capsule, myelinated. In this case, we can barely see myelination here in T2. So this is an hypomyelination with hypotonia, polymicrogyria, and I'm telling you, there are also some subependymal cysts. Putting all together, this is typical of Zellweger syndrome. So when you see isolated polymicrogyria in the context of hypotonia, look at the posterior limbs of the internal capsule, because this can be hypomyelinated, and also look at the ventricles for the presence of small cysts. Of course, you can have a lot of other causes of seizure, and these are several different cases. So you can have an insult here. So this was hypoglycemia. So you can see the oligeric appearance of the cortex. This is an insult, an ischemia basically at birth. This is Sturge-Weber. This is an MCA infarct at birth. So that creates this hole with gliosis that can give you seizure. This is lissencephaly, so genetic cause. There is nothing to do. But this, remember, this is very, very important. This is a diffusion-weighted sequence showing restriction in the thalami and globi pallidi and also subcortical, but the thalami and globi pallidi are very, very important, and this is vigabatrin toxicity. So when the child have seizure, especially epileptic spasm, they use vigabatrin that can give you acute abnormality in DWI. Please interpret this as vigabatrin toxicity. Do not look for a metabolic problem and neurogenetic problem. Finally, remember that we can use other techniques that are really, really, really important to help us in identifying the lesion. So This is T1, this is a T2. There is something wrong here. We are not sure about the EEG, so what we did is a PET. And the PET shows an area of hypometabolism in this area. So this is interictal PET, which is basically a PET while the child is not seizing. And because this area is abnormal, the metabolism of the glucose is abnormal, and you have an area of hypometabolism. So this is very, very helpful. This is another interictal PET with area of hypometabolism. Here you can see the difference between the left and the right. And this helped us to pick up the lesion that was missed before. So this is a peri-insular focal cortical dysplasia. Remember that in the insula region is very, very difficult sometimes to pick up subtle malformation because there is the claustrum, so gray matter in between, that gives you a lot of problems. Remember, you can do also ictal PET. While the interictal PET gives you hypometabolism, ictal PET gives you hypermetabolism, because in this case, the child is seizing from this area, and this area becomes hypermetabolic. And another important thing is that sometimes the lesion, as I told you before, 3 Tesla is better, but sometimes look at this. In 1.5 Tesla, the lesion in 2005 was better seen, while with the 3 Tesla and increased signal to noise ratio, basically we lost this blurring. So sometimes you have this pitfall. But how you can help yourself when you have this kind of tricky situation with epilepsy? Well, we can do other stuff. This is a magnetoencephalography, yes, MEG. And MEG measures basically small electrical currents arising inside the neurons of the brain. There are not many MEGs around, but this is very, very helpful. And because in comparison to EEG, the skull and soft tissue affect MEG much less. We can use actually a combination between the MRI that I showed before, the MEG, the EEG MEG, and the PET. This is the same case with confirmation of the area with the hypometabolism. So multi-parametric approach is very, very important. And finally, the preoperative planning. You know now, because I showed you this slide before, that DTI tractography is used to see the tracts within the brain, okay? So these are the tracts. Why the tracts are so important in epilepsy? This is the corticospinal tracts. This is the corpus callosum, and they control the movement of the patient. Now, why so important? Because if you have a lesion, look at this, okay? So this is in purple, the corticospinal tract overlaid on a flare sequence, okay? Look at that. And then something happened. This is a transmantle sign. This is a focal cortical dysplasia that runs very close to the tract. So this, I don't know why it's stop, okay. So runs very, very close here to the tract. And this means that the child will have high risk of hemiplegia after the operation. We need to see the tract so we can understand the perioperative risk. Oops, sorry. Okay, and this is just an example for literature where you have a lesion here, focal cortical dysplasia, highlighted in purple, and the relationship with the 3D reformat of the corticospinal tract. Okay, same thing for the fMRI. We have hand movement and feet movement. I will go fast on that because I told you already something about advanced techniques, but it's the same. When we move the hand, the area that controls the hand movement pop up, lights up in fMRI, and so we can identify the location of this area in comparison to the presence of focal cortical dysplasia. An example is also the language. So we use the fMRI for language lateralization. This is Broca area, this is Wernicke. If we have a lesion like an oligodendroglioma here, you see not only the lesion very close to the activated area with language tasks. So we can predict a lot of a basic problem after the operation, but also you, in children especially, you can understand whether or not there has been a compensatory activity on the other side. So that's very, very important in the preoperative planning, and also in understand the physiopathology of neuronal plasticity. And finally, what we do in our pre-op protocol is in some patients a CTA. Why? Because we don't only need the 3D reformat. You see, this is a 3D reformat that we did exactly in the same orientation as the brain when the surgeon opened the skull looking for the area to cut, and we overlap the vessels on CT that allows us and allows the surgeon to understand where are the vessel in comparison to the gyrus, which is pathological, to avoid complication due to strokes. So that's very, very important. And this is the last slides that I wanted to show. So the take-home messages, first of all, I'm very sorry that I was, my tone of voice was a bit sloppy, but really I have this bad headache today. I wanted to start video. Anyway, okay. Anyway, take-home messages are this. You have a lot of technical consideration to do in your imaging of epilepsy, in particularly with 3 Tesla MRI. That is the gold standard, but 1.5 Tesla 3D reformat, volumetric reformat are very, very important. As everything else, you have a lot of pattern recognition, and you can distinguish several diseases and use the multi-parametric approach. As always, this is recorded, so I will put on my YouTube channel at some point, but the slides are also on SlideShare. Having said that, I'm trying to go out from this somehow. Okay. And if you have any question, you can chat it, or